Hi everyone. So this is a case report that highlights the importance of physical exam. One of the main physical findings in this case was Quincke's pulse, and just as a review, Quincke's pulse is an alternating sort of flashing between flushing and blanching on the nails in sync with the cardiac cycle. And it's a manifestation of a high output state. Most commonly that's associated with aortic valve insufficiency, but there are other important causes that exist as well, and some of them we may just hear about in a minute. So for the case, this was a 74-year-old man. He had a history of chronic alcohol use. He was presenting with 2 months of progressive exertional dyspnea and weight gain. Pertinent exam findings included BMI of 34, blood pressure 177/56, JVP of 18 centimeters with normal waveform, unremarkable S1 and S2 without any transient sounds or murmurs, and Quincke's pulse seen in the fingernails. His labs were notable for a mild macrocytic anemia. He had a TTE that showed a dilated IVC with normal systolic function in both ventricles and normal valve function. So then on further workup, he had a right heart cath, which revealed a cardiac output of 12.6 liters per minute with elevated filling pressures, so consistent with high output heart failure. His thiamine was low at 39, which further specified the cause as wet beriberi. So he was started on thiamine replacement and abstained from alcohol, and that resulted in narrowing of his pulse pressure over time, which you can see in this graph to the right, and complete resolution of his symptoms without the need for any diuretic therapy. So along with some classic heart failure findings like weight gain, dyspnea, and elevated JVP, this patient had additional physical findings specific to the diagnosis. So if you recall, along with Quincke's pulse, his blood pressure was 177/56, so he had a wide pulse pressure. And these two physical findings, wide pulse pressure and Quincke's pulse, they're most often associated with aortic valve insufficiency, but they also are indicative of a high output state from any cause. And in this case, that was heart failure. So evidence of a high output state in a patient who's presenting with the clinical syndrome of heart failure should raise concern for high output heart failure specifically. And some causes include obesity, liver disease, myeloproliferative disorders, lung disease, severe anemia, thyrotoxicosis, AV shunting, and of course beriberi. It's important to specify when heart failure is secondary to high output and then establish the underlying cause in order to guide treatment, because it can actually be curative as opposed to many causes of other types of heart failure. In this case, the diagnosis of wet beriberi allowed for a specific treatment plan, so alcohol cessation and thiamine replacement therapy. This case really demonstrates the importance of distinguishing high output heart failure from other more common forms of heart failure and the critical role that physical exam can play in this process. So the findings of wide pulse pressure in Quincke's pulse can provide a really important clue to the diagnosis in patients presenting with heart failure with preserved systolic function, particularly when the echo is uninformative. So if these features of the case had gone unnoticed, this patient would have probably been treated with diuretics and diagnosed as HFrEF without any further workup, and that would have missed the opportunity for curative treatment. So now that I'm done talking, please check out the QR code in the middle of the poster to see the video of Quincke's pulse. And you can do this using your phone camera. Just hover over the image and the link of the video should pop up. So thank you for listening.